This short video illustrates the framework used by the Association of State and Territorial Health Officials through its Million Hearts State Learning Collaborative to support states in developing, spreading, and sustaining statewide systems that improve hypertension identification, management, and control. To learn more about ASTHO's Million Hearts efforts, visit our webpage at www.astho.org/million-hearts. The large blue circle represents an entire state. Within this state are many different communities represented by the smaller blue circles. These communities are supported by a variety of regional and state partners across a wide variety of sectors such as healthcare, public health, health information technology, clinical quality improvement, academia, state government, healthcare payment, and many others. And all of these communities and partners work together to improve hypertension identification and control within a broader context that includes many other initiatives at both the state and national levels to promote chronic disease prevention, healthcare delivery transformation, and more. Within each state, each community has its own unique population. Some communities may have many residents with high blood pressure. Others may have fewer. The residents of each of these communities may face a variety of barriers to controlling their hypertension, including lack of access to primary care or care coordination services, issues with taking their anti-hypertension medications as prescribed, lack of access to stable housing or transportation, or lack of access to community resources to support healthy lifestyle choices. Let's look at one of these communities in more detail. Regardless of the specific circumstances within this community, in order for it to optimize its ability to systematically identify community members with undiagnosed or uncontrolled hypertension and connect them to resources to help them bring their blood pressure under control, partners within the community must work together to create systems of care that span across all settings and include several key backbone features. These include close collaboration between clinical, public health, and community partners to identify individuals with undiagnosed or uncontrolled hypertension, gather and share data with other key partners, and refer individuals with undiagnosed or uncontrolled hypertension to the appropriate resources. Let's look at each of these backbone components more closely. Clinical and healthcare partners play several critical roles. They systematically identify individuals with undiagnosed or uncontrolled hypertension using clinical data available through electronic health records or chart reviews. They establish standardized hypertension clinical treatment protocols and workflows to ensure all patients with hypertension receive the same quality care. They refer individuals to community and public health resources for care coordination or to support self-management. And they track and monitor patients to ensure they follow through with their referrals and that their treatment plans are actually making a difference in improving their blood pressure. Local public health agencies also play a critical role in these community systems. They identify individuals with undiagnosed or uncontrolled hypertension using data sources available to them, which may include community-level hotspotting or prevalence data, data from direct service clinic electronic health records, community blood pressure screenings, and others. They develop standardized blood pressure screening, referral, and care coordination protocols and workflows, either for their own clinics or for community partners. They convene partners and stakeholders to coordinate efforts, leverage community assets, and address challenges. They support and leverage the workforce of community-based healthcare professionals, which may include community health workers, public health nurses, community pharmacists, emergency medical services personnel, and others. And they track and monitor individuals to ensure they follow through with referrals and are able to access resources that address barriers to blood pressure self-management. Community-based partners also play many critical roles. Some of them, such as faith-based organizations with parish nurse programs, may have data or information that can help identify individuals in the community with undiagnosed or uncontrolled hypertension who are hidden in plain sight. Others, such as libraries and barbershops, may have direct access to community members who may not otherwise be connected to the healthcare system and can provide opportunities for blood pressure screening and raising awareness. Other community partners may offer resources and evidence-based programs to support healthy lifestyles, such as the Stanford Chronic Disease Self-Management Program, the American Heart Association's Check Change Control Program, or CDC's Wise Woman Program. They may also offer services or resources to help individuals overcome barriers to blood pressure self-management, including anti-hypertension medication cost and access, access to healthcare and healthcare coverage, and access to social services. Or they may have a workforce of community-based healthcare professionals such as parish nurses, EMS staff, community health workers, community pharmacists, or care managers who can support individuals in monitoring their blood pressure and accessing the services they need. Community partners can also refer individuals to clinical care or other services as appropriate and help monitor them to ensure they follow through with referrals by sharing data with clinical and public health partners. In order for community-level systems to function smoothly and effectively, partners must share data and information with each other in a timely manner to ensure information is getting to the right person at the right time to inform referral, management, and follow-up. This information exchange is represented by the purple arrows and can take many different forms. However, ideally these data exchange systems are accessible to all key partners, can be used to generate actionable reports such as patient lists, registries, or hotspotting maps, and are connected to other state and local data systems such as electronic health record platforms or health information exchanges. These community backbone systems should also effectively move individuals between the services and resources these partners offer. This concept is indicated by the red arrows. This occurs through high-functioning referral and follow-up protocols and workflows that include roles for clinical, public health, and community partners. Each community approaches this work with its own unique combination of strengths, assets, and challenges. However, while each community may be very unique, it should still work toward establishing the same foundational backbone structures just discussed. Many regional and state partners also, across a broad range of sectors, also play important roles in supporting, spreading, and sustaining these backbone systems and best practices to all communities across the state. Some of the most critical partners are discussed here, but there are many others. The State Health Agency plays many important roles, including convening cross-sector partners to identify and align vision for hypertension management and control at the state level, identifying and securing state resources, supporting data access and systems, engaging leadership at the state, regional, and local levels, and much more. ASTHO has developed several resources describing in more detail opportunities for state health agencies to support statewide systems to identify and control hypertension. Both public and private insurers play critical roles in partnering with public health agencies and other state partners to address hypertension. Some of these roles include testing care delivery and payment models, aligning incentives for healthcare providers, patients, pharmacy benefit managers, and other stakeholders, helping establish and monitor quality metrics, accessing and sharing member data to identify members with undiagnosed or uncontrolled hypertension, or those who are not adhering to their anti-hypertension medication regimens, exploring opportunities to grow, train, and pay for the workforce of community-based healthcare professionals, supporting population health and chronic disease prevention programs for members and employers, and much more. Organizations who work on health information technology, health informatics, and clinical quality improvement can support regional and statewide data systems, help develop and align clinical quality metrics and other key hypertension improvement measures, train and support local clinical partners and other stakeholders in adopting a quality improvement model, and much more. Many other stakeholders also play important roles. Some of these partners include physician networks, hospital engagement networks, nonprofit institutes, universities, state hospital associations, state American Heart Association chapters, and employers. All partners at the state and local levels should coordinate and align across a number of key levers to advance and sustain broad systems change over time. ASTHO's systems change framework, pictured here, describes these key levers. And finally, as described earlier, all of this work takes place within a broader context that includes many initiatives that support chronic disease management, healthcare delivery transformation, and more. It's critical for states to consider how they can leverage these other opportunities to spread successful strategies and lessons learned to other communities across their state, as well as inform their work on other chronic conditions and public health issues. You can learn more about how states in the ASTHO Million Hearts Learning Collaborative are using this framework to establish systems to identify and control hypertension by visiting the ASTHO Million Hearts webpage at www.astho.org/million-hearts.